asking me to speak on this. And I had to reread the topic. First, when I read the topic, I thought it was urodynamics in children. And then I realized talking about toddlers. So that really, made my antenna go really high. So I looked up Wikipedia. Because what is a toddler? So toddler is somebody who just started walking and it's just about learning how to walk well. So that's that age group of 1 to 3. And then I looked through all my records. I'm somebody who does a reasonable number of pediatric UDS in Mumbai, but the number in toddler age group is rather tiny. And then to decide who are the children who really need urodynamics during toddler age group was a little bit of a difficulty, but I'll try my best. I am an adult urologist and I developed interest in pediatric bladder because we set up an independent urodynamic service about 25 years ago. And then by default, we started getting referrals. So many of my UDS patients are not my own patients and I have to make do with the data. However, before I start off with this, I listened to all the discussion which happened before my talk. And one question was, how do you make it easy for the child and for the parent? And it's very difficult in a toddler because the parent of a toddler is more difficult. So what I do, I sometimes, even if that means I spend more time, I ask them to come twice. Because that is not my patient. That patient has never seen me and suddenly I start putting tubes in the urethra. That's not a good thing for the child. So I make the child comfortable with me. The second thing is that people in my clinic during the time of urodynamics, pediatrics don't wear a uniform. Okay, a white coat, a nurse wearing a uniform, a ward boy wearing a uniform, that's the first thing the child hates. And so not having a uniform is the uniform code, especially for children. And third, because we run adult and pediatric UDS services, I segregate the days on which children are there. So if in the waiting area there is just one child and 4 adults, that child is not going to be very happy. But if in the waiting area there are 2, 3 parents and 3 children, then the child suddenly feels at home. So these are just some of my tricks, especially for toddlers. So having defined what is a toddler, the first thing is UDS is very rarely needed. Very, very selected situations where in a toddler age group, we need the urodynamic. So which are these selected situations? One will be, of course, meningomyelocele. All of us are familiar with that. And that is because we want to decide whether this bladder is safe or unsafe. Sanjay has made it clear very beautifully in his talk. And there are certain common patterns that we see, and we all know both in adults and in children that the level of meningomyelocele doesn't necessarily correlate with the bladder parameters. But it's good to know if it's a very low meningomyelocele, it's unlikely to have overactivity with DSD, and anything which is lumbosacral and above is a little more likely to have overactivity with or without DSD, as well as reduced compliance. So higher the meningomyelocele, you have to use your clinical acumen. Sometimes a totally lax outlet may be seen with a very poor outlet resistance as well as low contractility, and that is seen in lower form of meningomyelocele, lower level of meningomyelocele. In rectal malformation, I find these very challenging. There are 2, 3 issues. These children have loaded bowels. They have complex urological and anorectal anomalies. Some of them will have a colostomy, and you have to also know how to do a UDM with a tube through the colostomy. And to fix that to a colostomy can be quite tricky. They may not have had the full repair of anorectal malformation. A rectal exam can be very tricky. In ARM, it could be a fibrotic rectum. So these are the technical difficulties in these children. When would I do it in anorectal malformation? If it's associated with age-inappropriate symptoms, a very large residue, somebody who's constantly leaking urine, along with anorectal malformation, they would qualify even in a younger age group. And selected cases of valves, because all valves don't qualify for bladder evaluation in toddler age group. So you have to really decide those who are clinically not getting better, are getting unexpected infections, or showing deteriorating upper tracts by whatever imaging means, they would qualify. Again, a selected group of children who may be dysfunctional voiders. Again, that's something we don't see in toddler age group so common, but some dysfunctional voiders may qualify. So we all are by now very familiar with this, that bladder must do both the functions at low pressure, and any variation from this would merit evaluation. And we also know, since this is a pediatric neuro-urology workshop, I thought this slide is essential. We know what's the innovation, and S is for storage and P is for parasympathetic, P is for peeing. So that's something very easy to remember. So toddler urodynamics can be difficult, demanding, they can be depressing, because you may not always get the reply that you're looking for, but always ask still, why am I doing this test? What is it that I'm looking for? And how can I, to the best of my ability, bring out the pathology? The person doing the test must interpret it. You can't sit in the office and not examine the child at all, or you must have somebody very capable who's able to do all of that. That's why we call it urodynamic. Otherwise, you'll call it urostatic. It's not like an ECG strip that you read and say that this is it. The first test is the best effort, yours and the child's. As we already discussed, often 2 cycles are needed. Now, there is a difficulty in that because many of us use 2 catheters, and we do remove the second catheter during the voiding phase. And if you're going to do 2 cycles, then you need to be very astute in observing what are the changes in the first cycle, and you should know that is this child likely to need a second cycle, in which case you have to accept leaving the pressure, the filling line inside if you're using 2 catheters. Child-friendly atmosphere we already discussed. Urodynamics, more so in pediatric practice, is a culmination of everything else which happens before urodynamics. So you cannot just have a child for a UDS, you must know detailed history, you must know why are we doing it. Is there constipation? You know, big issue for urodynamics. We discussed about having an empty bowel, but not only the technical difficulty of the rectal line, but a loaded sigmoid colon is good enough reason to produce poorly compliant bladder and overactivity also. You don't want that colon to be sitting in the bladder. So an empty rectum and an empty sigmoid colon just above that. A good clinical exam will tell you all of that, a detailed neurology, prior review of all the reports. Again, because I run a tertiary service, I'm not following the children from day one. So there are some missing links, and if they're not there, I actually send the child back, or rather the parents back. So a prior review of all the reports, and those who void on command, toddler age group, that may not apply all the time, but if it's possible, have a wide record. So practical difficulties are when we listen to that cooperation of the child. Often video is required, and often video is difficult in this age group. Because to have a tiny baby perform best in front of a CM with so many people, so toddler age group, though video is required, video may not be feasible. The type of test we need is a very simple flowmetry in everybody who can void on command, and a cystometry with or without EMG, usually with a patch electrode, and video is very demanding in this particular age group. A separate MCU done before is often your best bet in evaluating, that can actually give you a guide as to how you should conduct the UDS. The aim is simple. Is it a safe or a dangerous urinary tract? This is just an overview of how we do it. Some of the pitfalls and artifacts which we've just listened to, the capacity, we know, use the bladder diary in that child if it's available, or use standard formula. Faster filling can actually lead to overactivity, and overfilled bladder can prevent the child from passing urine well. The question regarding antibiotic prophylaxis, my dear friend Mayang and I have always had this little bit of a tussle about antibiotic. Children who need urodynamics have an abnormal urinary tract. Very often they may be having UTIs, they may be having bad reflux, they may be having anorectal malformation with fecal incontinence. So you customize the need for antibiotics. Children are far more likely to need in toddler age group than adults. And we know all the standard parameters. I'm not going to go over that. But some of the technical points, toddler vesicostomy. So in a child with a vesicostomy, use a Foley catheter through the vesicostomy, little bit of traction so that you are using that to fill, and you are avoiding leakage by the side of the catheter. Those with a ureterostomy, you can actually put 2 tubes through the ureterostomy into the bladder and keep the urethra free so that the UDS can be done that way. And those who have a ureterostomy, but you've used a urethral catheter, you can use a dilute betadine to know you are able to see the reflux, actually, even if you didn't have a video. So I'm just going to show 3 cases because I had to be very selective in getting toddler cases to make some of the points. So this is a classic PU valve presented at 5 months of age, creatinine was 0.4, MCU was done, and the MCU is there in front of you. Had no fulguration, post-fulguration, he remained well. And the story will begin there. So about a year and a half later, so that means now the child is 2 years of age, creatinine rose to 1.5, and various options were there. The child had come with all of these things, and the question was whether the child requires a UDS. By the time the child came to us, he already had a ureterostomy. The creatinine had dropped to 0.6, and this was the repeat MCU. And as you can quite clearly see, the posterior urethra is not normal still, and there could be either a sphincter spasm or a stricture. There is reflux bilaterally, reflux through the stoma, you're able to see. So this kind of situation, we can actually put a catheter through the stoma. So we did a urodynamics because the question was, why is this reflux persistent? Why did the creatinine rise? And is this bladder hostile? Is there a prominent bladder neck? Is there a high pressure voiding? And is that a persistent valve or a stricture? So this child at the age of 2 years was also voiding on command. That's a little void, but there is an attempted bell. There is a very small volume. You can see on the top, the volume is less than 50. But for that volume, the Qmax is not bad at all. It's a tiny kid. And if you look at the cystometry, the question is this cystometry showing anything abnormal? This is a 2-year-old child. So if you see carefully, there are overactive contractions, high pressure overactive contractions, and there is leakage. With that leak, the child became a little settled, again overactive contractions, and during voiding, by which time we pulled the catheter out, the child started crying till then he was remarkably cooperative. We are able to see high pressure void. So this child's pressure is high, there is overactivity, the capacity is small. It's 65 if you see the bottom figure. So there is obvious overactivity, voiding pressure was high, there is no residue. So this child was followed up, oxybutynin was started, so on and so forth, and that impacted his overall health because I do have a follow-up of that child later on. I haven't put it here. This was a 3.5-year-old girl, recurrent UTIs, storage LUTS, diurnal wetting. So void record was asked, but they couldn't maintain the void record. That was what was told. She's leaking too much. She can't keep the void record. But she used to void on command. There was no constipation, satisfactory growth. Last UTI 2 months back, she was on antibiotic prophylaxis. Clinical examination was normal, and the sonography showed bilateral dilated upper trunk. Spine was normal. This was the MCU sent by the referring doctor. It was a fluoroscopy done in the OP setup. And if you see, there is a suggestion of a spinning top, then a bilateral reflux, both filling as well as voiding reflux. The reflux is going all the way in the upper tract, so it is grade 3, grade 4 reflux. With this in mind, she was sent for urodynamics. The first question is this reflux going to impact my volumes and pressure? Perhaps not so much, because it's not that huge dilated tortuous ureter. So we did a flowmetry, and she voided 76 mL. For that, it was a bell-shaped curve, not bad at all. The CMG showed a reduced capacity. If you see the figures there, the capacity was a little over 140. Why was it reduced? Because whenever she had an overactivity, which she had after 60 mL, she actually leaked completely. So this girl was leaking at 60 and 70 mL, leaking to completion. The voiding pressure was high, voiding was by overactivity. So was this urodynamics useful? In my mind, it was useful because it showed overactivity. In a child in the absence of infection, it showed reasonably good compliance till the overactivity set in. It also told that there was no residual urine, which we knew from MCU. The child wasn't on antimuscarinic. So after this, they probably decided to put the child. So has the UDS helped is the question that I keep on asking myself whenever a child is sent for UDS. If that question is not answered, I'll repeat a cycle. This was a meningomyelocele, 2.5-year-old girl. She had a sacral meningomyelocele, operated at birth. That means bladder bowel incontinence. She was in CIC already. The mom was doing it. There was no record of CIC. That is something that we should try and have it. She used to leak in between catheterizations. Man was doing it, not self. There was an indwelling catheter at night. Again, the volume not known, they would leave it in a diaper. Motion was alternate day. In my examination, the child was small, was walking unsupported. There was obvious cough-induced leak in supine position. Rectal exam, lax sphincter, rectal moving, so they had to do manual evacuation on table because otherwise we'll get completely wrong reading, and the creatinine was high. So there was enough information to tell us that this bladder could be hostile despite all the catheterization and indwelling cath and so on. So what does the urodynamics show? The sonography has shown bilateral dilated upper tract. MCU showed classic Christmas tree bladder, but there was no reflux. So this urodynamics, the capacity is 110. It was slightly low for a 2.5-year-old girl. The sensations were absent. She was completely unaware of anything happening in the bladder. The compliance is reduced, as you all can see, after filling about 40 ml, there is a steady rise. There is leak at 107 ml. How do you decide in such children that you are going to stop filling? As soon as they start leaking passively, you know that any further filling, they're going to leak outwards. What was the detrusal leak point pressure? About 38 centimeters at 107 ml. So this bladder is hostile. And that explains why the upper tracts are dilated. It's a poorly compliant bladder. It's a reduced capacity. Despite all the catheterization, indwelling catheter at night, the bladder pressures were still high. And this girl is clearly heading towards CKD. She's already having CKD, and the bladder is the cause. So the UDS gave the answer. So in toddlers, though the situations are not too many, the UDS, whenever required, it can be quite difficult. Expect an exact graph in a toddler can be a very tall order. Crying errors are inevitable. Whatever you do, how much of kid-friendly environment, a child will cry. A child cries during blood collection, child cries more during urethral catheterization. So it's impossible to have a baby who is docile. Normal urinalysis may not always be possible in children who merit UDS during a toddler age group, but what you don't want is a febrile UTI. And UDS is more of a corroboration of all your clinical features and not just the UDS trace. Thank you so much.